weight loss, and maybe change in bowel habits. Right-sided colon cancers, they bleed silently and presents with fatigue and microcytic anemia, while your left-sided cancers, they cause hematochezia and obstructive symptoms. But even when there is bright red blood per rectum and hemorrhoids are visible, you're not allowed to stop there. Any adult with unexplained iron deficiency anemia or rectal bleeding, especially over age 50, needs a full colon evaluation with colonoscopy to exclude colorectal cancer. So, next is spontaneous bacterial peritonitis. So, this is an ascitic fluid infection in cirrhotic patients without any obvious intra-abdominal surgical source, and the presentation can be very subtle. Low-grade fever with diffuse or localized abdominal tenderness, increased abdominal distension, or unexplained worsening of encephalopathy. So the step you must not miss is diagnostic paracentesis before antibiotics. Send the ascitic fluid for cell count with differential protein and albumin, glucose, LDH, gram stain, and culture. SPP is usually diagnosed when the PMN count is at least 250 cells per microliter, regardless of the culture result. Standard treatment is IV third generation cephalosporin, such as ceftriaxone or cefotaxime, with IV albumin in high risk patients to reduce the chance of hepatorenal syndrome. And survivors should go on long term antibiotic prophylaxis because recurrence risk is very high here. So, whenever you see a patient with new onset ascites, so this is spontaneous bacterial peritonitis, sits inside the bigger framework of portal hypertension and ascites. So, it helps to understand how the fluid got there in the first place. In cirrhosis, increased resistance to portal flow at the level of hepatic sinusoids raises portal venous pressure and drives the splenic vasodilation. So the arterial circulation is gonna react with activation of RAS, sympathetic tone, and ADH, which leads to renal sodium and water retention, and ultimately leads to third spacing of fluid in the peritoneal cavity as ascites. Clinically significant portal hypertension is also responsible for your varices, esophageal, mostly gastric as well, rectal too, and as well as splenomegaly and portosystemic collaterals. Um, Whenever you see a patient with new onset ascites, your first step is to calculate. You have to do the diagnostic paracentesis, not just for SPP, but to characterize the fluid. You calculate the serum ascites albumin gradient, which is SAAG, serum albumin minus ascitic albumin. So a SAAG of 1.1 or higher indicates portal hypertension, as in cirrhosis, heart failure, or bad Chiari, whereas your SAG below 1 to 1.1, it suggests non-portal causes like peritoneal carcinomatosis, pancreatic ascites, or TB. Uncomplicated cirrhotic ascites is typically high SAG with low protein, right? Ascites is managed with sodium restriction. You can give diuretics like spironolactone plus furosemide in a set ratio. Large volume paracentesis can be done with albumin infusion, and ultimately procedures like TEPS for portal decompression in selected patients with preserved hepatic function that we can do as well. Chronic pancreatitis can actually thrombose the splenic vein as it runs along the posterior pancreas, and that creates a very specific portal hypertension pattern. We will see only isolated gastric varices with a normal esophagus in a patient who has had recurrent pancreatitis. So these patients present with upper GI bleed, coffee ground, emesis or melena, and endoscopy will show large fundal gastric varices, but no esophageal varices, which should immediately make you think of splenic vein thrombosis rather than your classic portal hypertension from cirrhosis. Over time, this localized portal hypertension can cause hypersplenism with anemia, thrombocytopenia, and leukopenia as well. We have one more condition like bad Chiari. This is hepatic venous outflow obstruction from thrombosis of the hepatic veins or inferior vena cava near their hepatic entry. And exam questions lean on both the clinical triad and the risk factors. So acutely, you see right upper quadrant, abdominal pain, tender hepatomegaly, rapidly developing ascites, and sometimes jaundice too. Chronically, it ends in cirrhosis and portal hypertension with varices and splenomegaly. So the most important etiology to remember are myeloproliferative neoplasms like polycythemia vera, which is a hypercoagulable state of pregnancy. Oh, it can be, hypercoagulable state of pregnancy too, and the postpartum period as well. Oral contraceptive use, inherited thrombophilias, all can lead to but carry syndrome. So the first test you're gonna do is Doppler ultrasound, which shows absent or reversed flow in the hepatic veins, and management is indicated. It ranges from your anticoagulation to angioplasty, TEPS, or transplant, depending on your severity. There are two tiers. We will talk about these. The we Forceful vomiting is the trigger in both Mallory Weiss and Boerhaave, but the depth of injury is very different. For Mallory Weiss, their mucosal laceration at the gastroesophageal junction that causes painful hematemesis but do not traverse the full wall. They're often self-limited or treated endoscopically. Boerhaave, in contrast, is a full thickness transmural rupture of the distal esophagus after severe retching or vomiting, or usually in a heavy drinker. It can be iatrogenic too. The patient develops sudden severe chest pain, odynophagia, subcutaneous emphysema in the neck, and you will see signs of mediastinitis such as like fever, tachy, and hypotension. When you do the chest X-ray or CT, it shows you left-sided trilophian or pneumomediastinum, or even radiolucent band outlining the cardiac silhouette. So the mortality is very high if you miss this. So in the key diagnostic step in suspected Boerhaave is contrast esophagogram using a water-soluble agent like gastrographin to visualize the extravasation from the esophagus. The upper GA endoscopy is generally avoided as the initial test because insufflation and manipulation can worsen the perforation and push contamination into the mediastinum. CT with oral contrast is also frequently used in mesial leakage, and the treatment plan will be NPO, broad spectrum IV antibiotics covering your oral flora, and yes, urgent surgical consultation is required. So many patients need operative repair, especially if the perforation is large or presentation is delayed. I think that's it for this one.